Executive leadership in a new organization is our episode topic. My guest is Dr. Jerry Mansfield, a PhD prepared nurse and the newly appointed Vice President and System Chief Nursing Executive at the University of Texas Medical Branch in Galveston, Texas. This episode was recorded in mid January, a few short weeks before Jerry began his leadership at UTMB on February 1st. Prior to UTMB, Jerry has held 3 different chief nurse titles within the Ohio State University Wexner Medical Center and also held chief nurse roles at the Medical University of South Carolina, as well as the Mount Carmel Health System based in Central Ohio. Jerry was a Robert Wood Johnson Executive Nurse Fellow. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Jerry, thank you so much for joining us today.
Thanks for having me. I appreciate it.
Before we get into our episode topic today, executive leadership in a new organization, can you just share a little bit about yourself with our listeners?
So, been a nurse since 1983, was a proud graduate of a diploma program back at St. Vincent's Hospital School of Nursing in Toledo. First job in nursing was the Ohio State University Wexner Medical Center. And over a course of these many years of career, I was a typical nurse leader. You're a great nurse. You might be a good charge nurse. Then you're an assistant nurse manager, director, whatever. And eventually around 2000 was my first formal entry into nurse leadership. I was the first chief nurse for University Hospital East here in Columbus, Ohio, where they had acquired a for-profit OSU did from Quorum. And it was in an underserved area. And it was my first step into in 7 years as the chief nurse. And I really learned a great deal. After that, it was successive roles in nursing leadership at Ohio State. Eventually, I felt I needed to see what else was out there. On my way to Medical University of South Carolina, was there as their first executive chief nurse and chief patient experience officer in 3.5 years. Came back to Columbus because I was learning of some challenges at faith-based system, Mount Carmel Health, affiliated with Trinity, and wanted to help, wanted to see what I might do to help stabilize the organization, at least on the nursing side. I came back, that was COVID. I started in January, first COVID patient was in March, and it was just 2.5 years of just dealing with that pandemic. As we started to emerge from that pandemic, we really started to see stabilization in our nursing recruitment, our retention, our nurse sensitive indicators, patient experience scores. As of February 1st, I will be the Vice President and System Chief Nursing Executive for the University of Texas Medical Branch in Galveston.
You mentioned it earlier about great learning opportunities when you were at OSU East. So what was your greatest thing that you learned while you were in that role for 7 years at OSU East?
The first was taking on an organization that was for-profit and was really run into the ground by the for-profit organization. OSU took it over as this is something we want to do for the community. And I think what we learned early on was what the community wanted and what OSU's vision was a little bit disjointed. And what I mean by that is that the Franklin County Health Department did a study. And while people in the community were excited that OSU was there, they were very concerned that it was going to draw people away from healthcare in that community and maybe OSU would close it. Those are my words. But there was some great concern that while they were thankful, the employment opportunity for people in that community and the placement of that hospital was something that was very important to them. So it was, well, watch and wait and see an environment. And in that environment, that was the first time I had ever worked in a community-based hospital affiliated with an academic medical center. And so we had a lot of lessons to be learned. One was folks assume that now that Ohio State's there, folks will go to downtown and main campus for their specialized healthcare need. That's not what they wanted. They wanted it local. Two of the things that happened early on in the program was a reestablishment of cardiovascular care at University Hospital East. But they didn't want to drive downtown for that. They wanted it local. And the second one was oncology services. We have the affiliation with the Janes, and you would think that it's the Janes Comprehensive Cancer Center. People would want to go down to the main campus for that treatment, but that's not what they wanted. They wanted it local. So we established an infusion center affiliated with the James, of course, in one of our medical office tower offices. And what I learned through that process is that there's a relationship between, yes, I appreciate what I'm affiliated with, but I also want it where I live.
Yeah, for the benefit of our listeners, the driving distance, not necessarily actual mileage, but the driving time between these two sites is 10 minutes, maybe 15 during
Right.
rush hour, but we're not talking about a huge travel distance, but yet that desire to stay local on the near east side was still there, is what I'm hearing from you.
Yes. And I'll also tell you, Nick, you learn a lot about communities. And I, as a nurse administrator, had very certain ideas about what I expected in our environment. And I walked in one day to our main lobby, and there were blankets and pillows and things all over our main lobby on our couches and our chairs and everything. And I reacted. I just said, "Hi, what's going on here?" And it was very cold outside. It was a sub-zero night. And I notified the nursing supervisor, and I will never forget. She came to my office, put her hand on my hand, and she said, "Jerry, this is what we do when it's cold. We take care of the neighborhood."
Yeah.
She said, "I'll get it all cleaned up." And it was such a pause for me to understand that meeting the needs of the community is beyond healthcare, right? It's taking care of the people that live in and around that area. And I will never forget that lesson. And I totally tolerated blankets and pillows in the lobby after that, because that's where people came to sleep, because it was warm.
One question we ask nearly every one of our guests that's in a chief nurse role is what's keeping them up right now. I know that you're getting ready to move into a new role, getting ready to relocate. What's keeping you up right now?
Mostly what's keeping me up is thinking about the future. The pandemic taught us a lot about what's wrong in healthcare. We certainly did a lot of things right. I believe that truthfully. But the workforce has changed. What the workforce wants and needs and expects from leadership is different. People are going away from the nursing profession, not necessarily wanting to enter the nursing profession. So it's both an enrollment and a recruitment and a retention problem. But then while they're there, they expect flexible hours, an acknowledgement of work-life balance. So I think we as nursing leaders have to discern, what does that future look like? And I think we have to take into consideration that there aren't going to be enough of us out there in the future that we used to have, at least in the short term. And so we have to rethink how we deliver care differently. And when we begin to nudge at those edges about care delivery, people hunker down and say, this is why we do what we do. But I think it's an opportunity for us to recreate ourselves. And so what keeps me up at night is that uncertainty of what are we going to do? But I'm excited to join an organization that I think wants to think that through and from more of a cross continuum perspective, not just bricks and mortar. I'm actually excited to see what we might do differently. I think we have to open our eyes to a new future.
So you're embarking on a new leadership role in an organization that is new to you, and you've done this a couple of times. Can you talk a little bit about what your approach is when you enter a new organization and or a new leadership role?
So it always starts with assessment, of course. You got to go in there and figure out what really is the lay of the land. I look at it from 4 different perspectives and in this order, because I think in the order in which I'm about to describe it, that's key. The first is, what is the level of the nurse engagement in the organization? Are they part of the decision-making process? Do they feel they have a voice? Does it matter when nurses bring their opinions to the table? What does leadership do when they hear those things? And then, so we measure that both qualitatively and quantitatively. So I know There are surveys that they've done, and I will review those results and want to see where they're at. And then whatever they've got at that time, then work with the leadership team to figure out how do we embolden that voice forward, and then give staff the sense that we care about their opinions and we want them to be involved in decision making. That's the first one. The second one is our quality and safety indicators. So how are we doing with clottings and collapsings and hospital-acquired pressure injuries, all those things that people don't intend to get when they go to a hospital setting, but that causes harm. And then we want to count those and reduce those over time so that it gets to zero. Third is patient experience. So if the staff are engaged, if we prevent harm, would patients and families recommend the facility to family and friends? That's my true north. Different places will use like overall rating or some other indicators based on the survey that they use. But overall, I think that willingness to recommend the organization to family and friends is key. And what would the staff say? So if I'm in a grocery store and a staff member is shopping and a person comes up to me and says, would you get healthcare and name the facility? I ought to be recommending my own. And if I can't, I got to think through that, because that's where I work. That's where I apply my own practice. And so I think that relationship between what I do with my license or my care providing opportunities is I've got to feel like I'm part of putting it forward. And if I wouldn't even go to my own organization for healthcare, then there's a reconciliation point. And then finally, it's the financial performance. What is the cost to deliver service, like a patient day, an ED visit or procedure, an OR case? We've got to be thoughtful that we can't just add expense because it's just not going to be tolerated, especially in this country. And I think those are the angles in which I'm sort of my lens, that we in the United States spend a lot of money on healthcare, and yet our health outcomes are not as great as some other developed countries. And we've got to understand why that is. And there's certainly, it's a factorial issue, but health systems have to reconcile that sooner or later. So assessment, look at those 4 areas of performance, and then try to create a path forward that relates all of those indicators in which nursing is a contributor towards the strategic direction of the organization. So what are the things system or the university is trying to do in this academic case, University of Texas, and then say, how do we relate to that? Because wouldn't it be cool if I'm rounding on nights and I walk up to a nurse and I say, how are you contributing to the performance of the organization? And he or she can connect by preventing harm to the need. I help us meet that corporate objective. And then I, as the nurse executive, share that information with the nurse executive team and the board of trustees so that there's a very distinct line between what I do as a nurse and what the organization is trying to achieve. And there's a connection between the two.
What I hear you talking about is your role is really about connecting those dots to tell the story. You may
Yeah.
have already answered the next 2 questions with the way you laid out walking into the organization, but walk me through what your first 100 days in a new organization looks like, and then what the first year really looks like.
I think it depends on the organization in which you're in. And I think that's what I've learned over my career is that you just have to fit into where they are, plus see a vision towards a future that you think healthcare needs to be thinking about. So in this case, for me, it's starting out with the acute care side of the business, because that's the biggest part of the contributing both financial performance and just outcome metrics that are important to the health system overall. So the acute side, and then from inpatient beds, it's the emergency department, perioperative services, procedural areas. Then we got to move into ambulatory services and other outreach opportunities to see what is the role of the nurse in practice in those settings. And then my job is to try to ensure that everybody sees the full picture, because one or the other, all those things have to start to work together, especially now in healthcare, because our ultimate success, I think, in the future, Nick, will be the more that we can keep people out of our acute care beds the better we're all going to be. The only way to do that is through really engaged interprofessional teams to ensure that patients and families get what they need, stay out of the hospital. But when they do need hospitalized, we make sure that they don't get harmed, they get out soon, and they're well prepared to not be readmitted after their stay. And then, so I would see the first 90 days of just establishing relationships with not only with the people that report to me, but the executive team overall. I've been working very diligently to ensure that everybody sees that this is not just about nursing. It's about the interprofessional care that's delivered. The person I will report to, we talk a lot about how we show up together. He is a physician, I as the nurse, and how we engage people in what we're trying to do as a collective versus a silo. So I'm very excited about that opportunity. Also, getting to know the College of Nursing and the health professions, colleges at the academic health system, because that's an essential part of our pipeline for the future. And not just for the system itself, but for the citizens that are served in the state. Because nursing has learned through the pandemic that it is very mobile and they can go wherever they want. And sometimes name the ticket in which they are paid to do. We've got to be thoughtful about that. And try not to get into systems where we're unable to provide the care that we need to because people don't feel engaged in the work that's getting done every single day. I think after 3 months to 6 months, I'll have a lay of the land on what that looks like, work with a team to develop a plan. And then my job will be to ensure that there's a connection between what we've assessed, what we want to do as a group, how it relates to the strategic direction of the organization, share that with the executive leadership team, and then and then measure the effects of the work that we do. So another part of the job is to discern what are the metrics that people are interested in seeing change, and then watching on trend lines, are those moving in the direction that we hope?
How do you identify and prioritize your time, your energy, and your efforts?
I would love to say that I'm an expert at work-life balance, but I'm certainly not.
And I wasn't even
Um,
necessarily going work-life balance, even just work alone. How do you prioritize things there? Well, we can take that conversation any way you want to.
No, I think on the work side, I think it's a matter of once you get a sense of where we are in terms of the metrics and how the organization is performing, and you get a sense of what's important to the different professional people that are delivering that care, whatever the site, you look for some quick wins because it's important to establish some level of credibility that you're able to help facilitate getting some things done. But this is really for much more the long haul of trying to stabilize the workforce, if that's a concern, in the midst of healthcare that must transform to be more effective in the future. I really try to, and I will find out in the organization I'm about to join if this is tolerable or not, but I try very hard not to email people of small after 5 p.m. through the week or the weekends or holidays. Anybody can call me at any time. Call me. But I'm not an email reviewer after 5, before 6, and over weekends and holidays. And I do that too, not just for myself, but to honor the private time that people need to be with their family. That's one thing. The other thing I try to do also is balance personal reflection and growth along with professional. So I try to balance consuming enough industry information that makes me nimble in my day-to-day work. But I also try to do some things that are much more unwork related, but give me a chance of a little peace and respite after that. And recently, just two silly things. I drank quite a bit in my past career and I'm starting again. And I'm trying to be much more aware of our physical environment. So I'm actually quite excited to get back to Galveston. It reminds me of South Carolina. There'll be palm trees and marshes and ocean and the things that my wife and I enjoy. A little bit different than a gray, cloudy day in Columbus, Ohio today.
Does your time near the water remind you at all of your days at Cedar Point when you were in high school and meeting your wife? Is that the nature of enjoying the beach, or is it
It's interesting. That's a great connection, though. It started off my family and my grandparents purchased a cottage up in Michigan when my dad was in the Korean War. And so for my earliest days, our summer weekends, when we weren't at the grocery store, were spent at Long Lake, Michigan in a cottage. So Saturdays and Sundays, that's what we did. That was our vacation. And so always on the walk. But it was a mud lake and it wasn't that pretty. But it wasn't until I met my wife at Cedar Point in Sandusky. She and her family went every year to Myrtle Beach in South Carolina, and I hadn't been to the ocean. I'd never seen that. And so each year we would go down there and they have the same room in the same hotel on the same beach every year as a family. And I'm like, this is really cool. And so then, of course, South Carolina, we lived 5 minutes from the Isle of Palm Beach in Charleston and Mount Pleasant, actually. And to be able to walk out on your front porch and smell the sea air, and it's healing in a way for me. And I think that lapping of the waves on the beach is just part of how I get recentered on what's important. And of course, eating seafood is the other part of it. So
Yeah, there's two things you mentioned when you were talking about work-life balance and how you try to respect some of your other colleagues and subordinates about not sending out emails after hours and also necessarily not checking them. The schedule send feature in Outlook has been a wonderful addition where you can, if you choose to write something after hours, you can make sure it doesn't go until the next business day. And I've also seen some people that work different hours put in their signature line at the bottom something to the effect of, my work hours may be different than your work hours. Please don't feel obligated to respond to me outside of your normal working time. Have you used any of those functions or features, or what's that work when you got a 24/7 people that report to you?
it's funny. So there was when I first learned of the wait and send function in Outlook, I would do that and not send it until 6, 7, 8 in the mornings on Mondays. And then people would tell me they could tell I was working because their inbox would be flooded with feedback from me. So I learned to stagger my times a bit when they would send it to give them the illusion that here he's trying to catch up and this is working for him. But I'm not asking people to immediately respond. But I think over time, I think people learn that, and you work through this with a group. If you need me, the best way to reach me is on my cell phone. And don't text me, call me. I'll pick it up. Because that to me is a signal you need to speak to me. If it's an FYI, send me a message. And you can set up those rules, I think, early on in work relationships, but I think people, they'll test it because they just want to make sure. And then you also have to be respectful for the people that you report to of how do they want to be connected with. But so far, I've been very encouraged with this new opportunity that I'm about to join. And it's early, I haven't started yet, but the responsiveness of this leadership team has been extraordinary. And I'm hopeful. I'm hopeful that what I see and what I sense is what I'm going to experience when I'm there. And I think I think it's a good fit. We shall see.
The way you've answered previous questions is the answer may just be no, but I figured I'd ask the question. Have you identified your priorities yet? And if so, what are they?
No, not really, Nick. I think the first is I don't think there's any burning platform per se at the organization. At least that's not what I sense. I do believe that they sense the system and need to recreate itself for the future differently than what it's been in the past. It is an island, so Galveston, it's off the main coast of Texas. And there might be some recruitment and retention opportunities in relation to some competition with other health systems in the area. But I think those are things that we will just work through and pay attention to. In fact, they're doing very well in terms of many outcome indicators for patient care. So I don't have any definite sense of concern there. However, there is a need to establish a stronger relationship between the health system and the College of Nursing for recruitment and retention. That's definitely an area of opportunity. Don't know why it exists the way it is, but the new dean and I have talked about that, looking forward to working with her. And she and I have held board positions at the American Association of Colleges of Nursing together. And in fact, I will see her next week at an annual conference, but we definitely want to work on academic practice partnership relationships to really strengthen the connection between the new graduate and the practice setting to ensure that the nurses are safe and ready to practice when they start and learn together as we go through. Because I don't think recruitment for students is their issue, but recruitment of their students for our house system has been a challenge. And I'm not sure why, but we're going to focus on that.
Yeah, we're actually going to be talking in another episode about aligning practice education and regulatory practice and the academic practice partnership. It's old school, but it's so important. And in today's workforce environment, it's interesting that some of those things gone away to the wayside, perhaps during COVID or just from the nature of the grind, so to speak.
If the pandemic taught us anything, when we shut down our clinical rotations and sites for any clinical provider for any health profession during pandemic, we did that because we weren't sure we had enough PPE. We weren't sure how the disease was going to spread. All the right reasons to do that, but not allowing those students back in earlier, I think was a huge mistake. And that's one thing I hope we never do again, because then we had students coming out of colleges and universities with very little hands-on clinical experience. And at the same time, there were a lot of more tenured nurses that left and traveled and did whatever they wanted to do. So a new grad would look to their right and their left and not have that experience level that they could rely on to help them discern when is this important to escalate and when is it not. And so one of the things I want us to do is ensure that whatever we're teaching and whatever the student brings forward in terms of clinical skills and knowledge, wherever there's a gap, let's just know what that is so that the handoff is solid. And this is in the midst of, we had nurse transition programs, nurse residency, nurse fellowships, but the health systems had to shore that up quite a bit.
You've held a chief nurse title 5, soon to be 6 different times. Can you talk how similar those roles have been from one tenure to the next and how different the roles can be?
I think what I have desired to do is in each of the roles, those things I talked about earlier in the podcast, the staff engagement, quality and safety indicators, patient engagement, experience, financial performance, all of those things are magnet-esque. So the one thing that I try to do, whether an organization is intending to go on a magnet journey, a pathways to excellence, whatever you want to call it, those things matter. And those things matter because when you outperform your benchmark peers in those 4 areas, you describe a relationship about the contribution of the nursing practice, how the organization is going to perform and move forward. And you can't do it without nurses. So that's what's similar. So I always go in and I try to figure out how are those 4 things being managed and elevated in the organization, or they connected to strategy. Then what's dissimilar is, I think it's more the relationships, how you get the work done.
Yeah.
It's not everybody's on the same page. Not everybody sees it through the same lens. And how you get to the outcomes you need and should be producing on behalf of patient care, how that gets done can be different. And you got to work through the interprofessional relationships on how that might happen. And I'll tell you, one of my best experiences in my last job was working with our chief clinical officer. He and I, when we would show up together on rounds and to talk to staff, just talk to them. I'm the nurse, he's the doc. Those moments where we both saw excellence in action and or gathered information that we could take back to the executive team, that was our secret sauce to success, because that really informed the board of trustees, the executive leadership council, and what we were watching, what we were paying attention to. And so in that environment, that relationship between the two of us, what I think was something that I really learned that was of great value, not only for ourselves, but for the system itself and the folks that we worked with. And I cherish some of those rounds and the things that we saw and heard from staff. It was wonderful. That different than another organization, Medical University of South Carolina, huge focus on 2 things. 1, get magnet again. And 2, exceed patient experience scores. 90th percentile overall rating. That was my charge. But in those environments, MUSC was very physician-centric. There were service lines that were led by administrators who were not clinicians and doctors. And then we had a corporate leadership team that was trying to move forward on those two elements, magnet, patient experience. But I think the brilliance was they got one guy to be the lead for that, which was new. But it was a lot of work, but figuring out how to work with those people and then within those relationships to get both accomplished in an academic environment it was a lot to figure out. So I think back to your question, I think there are some things that are similar and there are swim lanes that you got to figure out and then track performance against while you're figuring out how to get that work done within an environment. And I think our third challenge today in healthcare is just, we got to figure out how to do it different because it's going to have to be different and sustainable.
What advice would you have for a nurse leader entering a leadership role in an organization that's new to them?
I think the first one is listen, suspend your assumptions. And I think the third is to watch and lean into connections that people may not have seen before. So one of my favorite parts of my experience has always been when I'm sitting in meetings and I'm hearing dissonance and there's tension and there's people who have an opposite opinion about a topic or an issue. And what I'd like to discern is a way to weave a needle and a thread through the disparate comments into at least something we can agree on. We agree on this. Just say, we're really not that far apart from what we're hoping to achieve. They're connected. And if there's value in what you said, and if there's value in what you contributed, if we link them together, what might we do? And so I think a new leader has to, again, be very thoughtful about what they're hearing, validate what you hear. What I heard from several different places and or see connections between metrics, so maybe there's a chance here to do something about that. And the other way is to also be thoughtful about how things connect when people think they may not, and discern ways in which to bring folks together to think of a new way of approaching something. Because as a leader, I don't have all the ideas. I don't have all the solutions. Absolutely not. My job is to make sure that whatever we're approaching and dealing with, we've got to get through. What's my role in helping us get through whatever we're challenged by? And I think the last is watch. Who is connecting with who has influence formally and informally beyond the organizational chart, and then leverage that knowledge into change.
Any closing thoughts as we wrap up this episode?
Well, Nick, you and I have known each other for quite some time. And so I have appreciated that relationship. So if it's okay for you to share that on this cast, that would be great. But I think as I look at my career over the past, it seems like 150 years, there's so much of what I am appreciative for. And one of them is I've always tried to go to things that I'm uncomfortable with. And sometimes people shy away from stuff like that. But what I try to do is say, if I have an uncomfortable part of dealing with something, then I got to learn more. I don't have to be an expert at it, but I can't ignore it. And so I think I would encourage future folks to just go to where you fear, learn, discern, and you're gonna get something out of it somehow, some way, and then collect all the stories that you see where great care is delivered, and let them sustain you when the days get tough sometimes.
Jerry, thank you so much for spending time with me today to leverage your knowledge and expertise as you get ready to embark on your new role in a new organization. I appreciate your time and best wishes to you.
Thanks so much, Nick.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.